Dr. Milind Alokji. Good evening, sir. I'm Dr. Milind Alokji, third year DNB PGT from MR Bangur Hospital. My patient, Mr. XYZ, 53-year Hindu gentleman, resident of Howrah, Kolkata, and a farmer by profession, came with the chief complaint of loss of appetite and loss of weight for the past 5 months and upper abdomen fullness for the past 2 months. The patient was apparently well 5 months back when he first noticed a loss of appetite. He complains that this feeling progressively increased, as initially it was not marked, but more recently he has started avoiding meals. He also complains of weight loss over the past 5 months, which he says has been around 10 to 12 kgs. He has further noticed a fullness in the right upper abdomen for the past 2 months. This fullness is not associated with any pain, any aggravating or any relieving factors. There is no history of fever or pain abdomen. There is no history of trauma, no history of yellowish discoloration of eyes or urine, no history of passage of clay-colored stool. There is no history of heartburn, regurgitation or fullness after meals, no history of vomiting, no history of any loin pain or hematuria. There is no history of any other swelling in the abdomen or the neck, and there is no history of any cough, hemoptysis, breathlessness, or any history of back pain or swelling in lower limbs. There is no history of any major medical ailment of the past, and no previous hospitalization or surgeries, and no history of any similar complaints. And patient also does not have any known comorbidities. The patient is married, has 2 children, 1 son and 1 daughter, and both are healthy. He consumes a mixed diet, is a chronic alcoholic, and has been an everyday smoker for the past 30 years, has a normal sleep pattern. Bowel habit, he's passing well-formed stool once a day, no bleeding PR, no passage of mucus in the stool, and no recent change in bowel habits. The bladder habit is also normal. Both the parents of the patient are deceased, but they passed away due to natural causes. 1 female sibling is there, 50 years old and in good health condition, and there is no history of any cancer-related deaths in the family. The patient has not taken any treatment or received any intervention prior to this current illness, and he has no history for this current illness, and he has no history of any allergies. In summary, a 53-year Hindu gentleman, resident of Howrah and a farmer by profession, came with the chief complaints of loss of appetite and loss of weight for the past 5 months and right upper abdominal fullness for 2 months. The loss of appetite has progressively increased, and more recently, the patient has started avoiding complete meals. He also complains of weight loss over the past 5 months, which he says has been around 10 to 12 kgs. He further complains of right upper abdomen fullness for 2 months, not associated with any pain, any aggravating or relieving factors. He is an everyday smoker since the last 30 years and a chronic alcoholic. Bladder and bowel habits are normal. There is no history of any previous episodes of jaundice, blood transfusion or hematemesis, and no history of suggestive of metastatic disease.
Nice history. And you have very comprehensively covered a lot of things. But there'll obviously be a few things which would still get better, because as we present, the intention is to just make it better.
Yes,
so one is about, I think the history of present illness was decently put forward, and you're trying to create a case for yourself. That's perfectly all right. But don't make it look so focused that your views about other conditions just disappear. The question about history of trauma, what was in your mind when you were taking history of trauma? Because if you look at the presenting complaints of your patient,
yes,
they have nothing to do with trauma, right?
Yes, sir.
Why did you take that history?
So since it's a case of abdomen, sir, and to cover that aspect, sir, because some kind of a trauma might present as a...
1 minute. So you answered that. So your smile says it all. It's not relevant, so it doesn't make sense. Similarly, the loin pain with hematuria. So you mentioned at some other place, no urinary complaint. So what exactly specifically you were looking for?
Sir, since it's a right upper quadrant fullness, and since the other complaints are vague, I just wanted to rule out the systems that might be involved.
Good. You made a point. Through you, I'll be able to teach the other students also. It is not required of you to cover up everything and whatever is related to it just to make sure that your right right hypochondrium, right upper abdomen is all covered. That's not our intention. The intention is to, make a diagnosis at the end of it. So if you were to take a history in any patient, you're taking it basically because you want to make some diagnosis.
Yes, sir.
Okay. So that's being absolutely vague, what you just mentioned. I hope you don't mind it. I'm not trying to pull you down because I like the way you present it, but you brought in many unnecessary things simply to cover up for those who may ask you those stupid, silly questions like, why didn't you take history of trauma, pain in the upper abdomen? Why would you? It's no. First of all, loin is not in upper abdomen.
Yes, sir.
Okay, it's in the flank.
Flank, yes, sir.
Secondly, patient would be telling you that history. Unless you find it relevant to your case, which you have finished already now, how would you be able to relate it to this? You won't ask every other patient with that history, with that, presentation, these questions. The third thing was about, I am very particular about this particular point actually in past history. No similar complaints in the past. Now, the history is 6 months old. Now, what specifically you were trying to ask, you can mention rather than saying similar complaints, because his complaints are loss of appetite
And loss of
progressively worsening, loss of weight, which is progressively worsening, right upper abdominal heaviness. I won't call it pain, as you correctly said, except that there's nothing else. Am I right?
Yes, sir. Yes, sir.
So which complaint you're referring to when you're saying no similar complaints in the past? So it's not necessary because you've already covered the other aspects. So what past history is important in this patient, we'll discuss.
Okay,
But
sir.
don't make it a journal statement that no similar complaints in the past. So we find out what the complaints are, then we look for the past. Fourth question is about your family history. Nicely taken. And family history is a very important history. You mentioned no cancer-related deaths in the family. Everything is perfect. I mean, I'm just trying to say that it was the right way of approaching it, so that you are able to, use it for your diagnosis. The rest of the other points that you mentioned may not be relevant to your case.
Yes, sir.
It is better to avoid unnecessary garbage, because that dilutes the quality of a good history.
Okay, sir.
You took a good history, but you brought in some unnecessary points. So where did my mind go? My mind went to the unnecessary things.
Yes, sir.
If you keep it focused on what you wanted to say. Any patient with right, you already have examined, you've already seen the case, and you're suspecting it to be a liver mass at the end of the day. I'm not saying now, you would have finished by that time. So when you're presenting your case, you've already done everything. So
Yes, sir.
you can't pretend to be not knowing at that point of time and just unnecessarily asking questions and wasting your time and my time and everybody else's time. So that is what I was trying to submit for your own good, right? It
Yes,
is
sir.
important he's a smoker. It's important he's a chronic alcoholic. It's important that bowel bladder habits are normal. These are important questions.
Yes, sir.
But so many unimportant ones came in that it got a little diluted. Otherwise, I liked your history very much.
Yes. Actually, the point is, once you have a patient at the end of your examination, find hepatomegaly and probably find a hepatic mass, then you should make a history taking out to exclude a metastatic disease. So you should ask the relevant points as pointed by Dr. Chintamani. We may not go to the just a remote diagnosis of a metastatic disease.
One more point, if I may, Dr. Saad. This is no history is suggestive of metastatic disease. It's a beautiful thing to ask, but it is distant metastatic disease, right? So
Yes, sir.
you can mention specifically so that some examiners like it. They may
Okay, sir.
ask you that question so that you can earn one question. And I am reinforcing what Dr. Saad just told you. After you've done everything, you know the case.
Yes, sir.
You can't be beating around the bush in the history. That is the idea, right?
Okay.
Can we move to examination, Dr. Saad?
Yeah.
Yeah, please.
Yes, sir. The patient was examined after taking informed consent in a well-lit room and with proper exposure. The patient was conscious, alert, and cooperative. Karnofsky performance status was 80. Build was average. Decubitus was of choice, and the BMI was 90. The vitals, pulse rate was 86 beats per minute, regular in the right radial artery. Respiratory rate 15 per minute. Blood pressure 122 by 82 millimeters of mercury in the right arm in supine position, and temperature was 98.3 degrees Fahrenheit. Pallor was present, and but other than that, there was no icterus, no cyanosis, clubbing, generalized lymphadenopathy, or edema. On inspection, now coming to the abdominal examination, on inspection, the shape of the abdomen was scaphoid, the umbilicus was central and inverted. All quadrants of the abdomen were moving proportionately with respiration. Our fullness is noted in the right hypochondrium. There is no erythema, sinus scars, or dilated veins, no visible pulsations of peristalsis. External genitalia is normal and hernial orifices are intact. On palpation, there was no local rise of temperature and no local tenderness, no guarding or rigidity. The liver is enlarged and the margin can be palpated about 5 centimeters below the right costal margin. A solitary nodule of about 3 centimeters is palpable on the liver. There is no other mass palpable, no other organomegaly. Renal angles are normal, hernial orifices are normal. Sir, I'm sorry, I missed another point. The liver otherwise is smooth, and there is no irregular surface or margin. On percussion, the liver dullness extends about 5 centimeters below the costal margin in the mid-clavicular line. There is no free fluid. Auscultation, normal bowel sounds are heard, and there is no bruit heard over the swelling. On digital rectal examination, there is no fissure or hemorrhoids. The tone was not raised, and fecal staining of the gloves was present. Systemic examination was within normal limits. In summary, a 53-year Hindu gentleman, resident of Howrah and a farmer by profession, came with the chief complaint of loss of appetite and loss of weight for 5 months and right upper abdomen fullness for 2 months. The loss of appetite progressively increased, and more recently, the patient has started avoiding complete meals. He also complains of weight loss over the past 5 months, which he says has been around 10 to 12 kgs. He further complains of upper abdominal fullness for 2 months, not associated with any pain, any aggravating or relieving factors. He is an everyday smoker since past 30 years and chronic alcoholic. Bladder and bowel habits are normal. No history of previous episodes of jaundice, blood transfusion or hematemesis. No history suggestive of metastatic disease. On examination, the patient has a BMI of 19 and a pallor is present. The remaining general examination is unremarkable. Our fullness is noted in the right hypochondrium on inspection of the abdomen, and on palpation, liver is enlarged, smooth, and the margin can be palpated about 5 centimeters below the right costal margin. A solitary nodule of about 3 centimeters is palpable on the liver. There is no other organomegaly, and systemic examination is essentially normal.
Yeah, when you're summarizing, I think it's again very nicely done, but when you're summarizing it, then you don't need to mention about BMI and pallor. Now you can say malnourished.
Okay, sir.
And you don't have to describe fullness in the right hypochondrium. You can simply say hepatomegaly.
Okay, sir.
And rest is nicely done, which there is hepatomegaly 5 centimeters below the costal margin. How much is the liver span?
So liver span, sir, in the so the inferior margin is felt right below the right costal margin, sir. So a 6 to 12 6 centimeters in the mid clavicular line, sir.
What is the? You mean the liver span is 6 centimeters only?
No,
No,
it's
sir.
below the costal margin. Span is the whole liver
Yes, sir.
dullness.
Span is something else, Bachu. 5 centimeters below the costal margin, I can read.
Yes, sir.
So
And above.
how do
If you
you
start from above,
calculate the liver span? You start.
normally is about
So on
10 to 12.
yes, so we start percussing from the second intercostal space, and so then we come down, and so the liver dullness we see in the mid clavicular line and in the mid axillary line.
So how much is the normal liver span?
So 6 centimeters. I'm
No,
6 to
no.
12 centimeters.
It's
Okay.
a long gap. 10 to 12 centimeters are normal liver span.
See, it's a huge. You're totally off target. Therefore, I would not be interested in 5 centimeters below the costal margin again and again. Once you mention, then I need to know the liver span to know whether liver is actually enlarged or not. My concern is whether there is hepatomegaly or not, or is it pushed just because of the, it could be pushed from above also. No, that is why. So that liver span should have come out more clearly in your presentation. Can you go back on the slide just before this?
So this one.
No, go to the examination. General examination, yeah. So when you're saying Karnofsky, this is common. It's not your fault. Karnofsky performance status is 80. No, that's not correct. The performance status is 80 by Karnofsky scale.
Okay, sir.
Okay. The built is average, decubitus of choice, and BMI is 19, which is fine. And that doesn't make him malnourished. 19 otherwise, based on BMI, is not malnourished.
Yes, sir.
But next slide, but on account of pallor, patient is malnourished. So pallor should come in the nutritional status. So therefore, rather than getting the pallor here, you could have put it down as performance status, nutritional status, and hydration status. They could have come up front and you could have finished the issue there only. Performance status is 90 by Karnofsky is again an issue because 90 is very mild symptoms. That's okay, 80, that's fine. Now, and built is average, decubitus of choice, BMI and pallor is positive. On account of pallor being positive, patient is malnourished.
Malnourished.
Next slide. This is fine. You kept it very brief, so that's okay. Now here, you haven't shown us the picture of the case. Otherwise, I would have been more emphatic on this. Please avoid using the terms like scaphoid abdomen. You don't get to see it. It is seen in very malnourished individuals. Can be seen. I'm not saying that you cannot see it, but it is not so common. So therefore, if it is not distended, you're fine. So rather than calling it flat, which again is something you observe very commonly used, which is not usually the case. What is a scaphoid abdomen according to you?
So scaphoid abdomen, sir, where
so you don't
From
know.
xiphoid to symphysis pubis. So take that line.
If you know scaphoid bone, it looks like boat, and the boat looks like scaphoid bone, and they both look like each other. This goes on. Basically, it is a abdomen where a lot of fat has been lost and muscles are also gone. The tone is gone. So classically, by putting a ruler or a scale from xiphoid process to symphysis pubis, if you find the gap between the anterior abdominal wall and the scale to be more than about 2.5 centimeters, they call it scaphoid abdomen. It is seen in very malnourished individuals, cancer stomach patients, terminally ill patients, or even in some models that are trying to have that kind of appearance. So again, due to malnutrition, you can say. So basically not something you will observe commonly.
okay,
But I don't
More like a Boeing. It's more like a Boeing.
So it is unusual, unless, and if your case had it, then that's okay. But it's unusual, right? You didn't show the picture, so I couldn't make out. And all quadrants are moving well with respiration. Fullness is noted in the right hypochondrium. What is right hypochondrium?
Sir, right hypochondrium, sir, say if we draw a line, tip of the two.
Very tiny space. So
Yes, sir.
fullness could have been extending beyond that. No?
Yeah. Should be right upper quadrant, you should better say.
You can better say that, right?
Upper
Upper
quadrant.
quadrant is all having fullness. Can't be hypochondrium though. You may jump to external genitalia straight away. Finish with abdomen, then come to all these subsidiary accessory things. Next slide. Now, we were interested in the umbilicus, so you mentioned it. We are also interested in the veins around it, caput medusae, etc., because that is what you look for.
Yes,
They're
sir.
not there. I'm not saying it is there. So it is important to mention that. Next. Now, this local rise of temperature would be indicating what to you?
So any kind of inflammatory pathology that would,
Okay.
or any kind of
If the
collection, sir,
patient
in the abdomen, sir, in the
patient has, you see have so many peritonitis patients every day, and you see, liver abscess patients also. The skin temperature does not rise because it has to, you're looking for temperature with the back of your fingers as you do normally. So you're looking at skin temperature only, no? So for any inflammation which is intraperitoneal, to traverse through the layers of the muscle abdominal wall and then reach the skin would be something unusual. It is a commonly used term, so I thought I'll correct it for you and it will help others also. Similarly, don't comment on it because unless the patient is febrile, where the temperature is raised all over, abdominal local rise of temperature can only happen if there is a parietal abscess, which is closer to the surface. Otherwise, it won't happen. Now, no guarding rigidity, no local tenderness, liver is enlarged, and the margin can be palpated. This is where you would have finished with liver completely. You said liver is smooth. Liver is not smooth. It's the surface that you're talking
yes,
about.
the surface of the liver is smooth, sir.
And there is a nodule 3 centimeters. Describe this nodule in detail. Is it the same consistency as the liver, or it is different? That is required here. So what was it like?
So it was a firm nodule, sir.
And how was the rest of the liver?
So the rest of the liver, sir, so the rest of the liver was unremarkable, sir. It was not of the same
What
consistency,
could be
sir.
the consistency if liver is enlarged? It will
Sir,
also be firm because you are palpating through the anti-abdominal wall.
yes, sir.
It can't be cystic.
Yes, sir.
If it is not hard, then it is firm only. If it was hard, you mentioned hard. So
Okay,
the consistency of the nodule and liver is they're both the same. So it's a part of the liver itself. Otherwise,
Yes,
it could be something in addition to liver. It could make a difference. Okay, so these are some observations in this slide. Next slide. Maybe I'm missing a few. Next slide. Now you mentioned liver dullness extends about 5 centimeters. This is not going to help.
Should be spent.
You should have
Okay, sir.
mentioned the span. We have already told you that. And
Yes,
no bruit heard over the swelling. You were trying to look for what?
So, so any kind of abnormal, so any kind of pulsation,
Basically, any any vascular and
vascular, yes, sir.
or related to liver. You can be having hemangiomas or AV
Most
malformation,
common.
or otherwise also, which liver is usually pulsatile.
Pulsatile. So if there is if there would be
Two conditions I have told you. The third one is in tricuspid incompetence, because of the conductive. That is not relevant here, so we will not waste your time. Now coming to the DRE, it's very important examination in all abdomens, but don't just stick to fissure, hemorrhoid, stone, and fecal staining with gloves. You don't expect anything else there. Patient is passing stools every day. What is the reason for doing DRE here? Patient has got a liver swelling. So one is you have to mention
so
there
to
is no
rule
growth.
out, yes,
Or
sir.
say
If
it's all normal. One is no growth.
yes, sir.
Secondly, rule out any portal. You should do proctoscopy to rule out any portal piles, as they call
Yes,
them,
sir.
or any varices of that kind, that whatever you call them, and any deposits in the rectovesical pouch. Then we would have made some sense out of it.
Yes, sir.
Otherwise, just to mention tone and fissure, hemorrhoids, which are not present also, makes no great sense here. And then, yes, it is good to rule out melena is not there, no other things when you bring your finger out. So fecal staining of gloves is not enough. You must mention these things in a negative observation. Next. Now, you can't say neck, no nodes. Why did you look for neck?
So, although, sir, usually, sir, if we are considering a liver mass, the metastasis would not be there, sir, but neck nodes are one of the
No, it
places
is
where
not
Which
relevant
node?
for your abdominal examination, except
Yes, sir.
the Werkhaus node. So if you had mentioned no Werkhaus node or no, the scalene node, then that would have taken care of it. Otherwise, you don't expect the neck nodes to be. But you already mentioned no generalized lymphadenopathy.
Yes, sir.
Neck, in this case, would be a part of the general system. No, it's another region. So unusual. No foconeural. Others are all normal, right? That's what you're saying. Next slide. Now that's your summary now. In the summary, you can't be repeating what you have already mentioned. This would have been 53 year in Hindu. I am not bothered unless this disease is commoner in Hindus. Is it true?
No, sir.
So don't have to highlight. It doesn't make any sense. Now 53 year known alcoholic and smoker presenting with significant loss of appetite and weight in last 5 months and right upper abdominal fullness, right hypochondrial fullness for last 2 months. Now we are talking a doctor language, right? Baki, the rest is not required,
All right, sir.
I have already described it. On examination, the patient has
Patient is malnourished.
poor performance. It is not good, no? Poor performance status, and is malnourished on account of anemia or pallor. You don't have to mention the remaining general examination is normal. That is not required. And has got a hepatomegaly, which is with the liver span of this much, which is firm in consistency with a nodule. So it will be nodular hepatomegaly. If this was a hard nodule, what sense would it make to you?
Sir, sorry, I did not hear
If
you,
it was
sir.
a hard nodule and the rest of the liver is firm,
Yes, sir.
then what would come to your mind?
So if it's a, so then we would investigate on the lines of a solitary nodule, sir. Liver mass, most probably a
No, if the liver is
malignancy.
normal, it's firm in consistency and it's a nodular liver, we are suspecting it to be metastatic disease.
Metastatic disease.
But also liver there also changes gradually. So it doesn't remain firm for all this while. It also becomes hard. But the nodules consistency being similar to the liver makes it one of the nodular disorders of the liver. Is that okay? And then
Yes,
that
sir.
could be many conditions, whether it's cirrhosis or it is a dissolving or resolving or evolving cirrhosis. All those things come handy. This was a bit of what I understood from what you mentioned. So these things could be added and few could be excluded.
Yes, sir.
So now you made some impression. I agree. It's important to mention no previous history of jaundice blood transfusion, but you already described it.
Yes, sir.
You're trying to take away the certain conditions from your mind. One thing that did not emerge in your entire history, which is very important, any history of, I'm asking you,
So,
what kind of an exposure?
high risk behavior, sir.
That high risk behavior should have come out in a big time way. Why is it important?
So, because high risk behavior might lead to the spread of hepatitis B, and that is one of the most important environmental factors related to hepatocellular
That's
carcinoma.
only one, and I have always heard people get stuck there. HIV increases the risk 3 times, 2 to 3 times. So even that is important.
Okay, sir.
HIV adds to the risk of hepatocellular carcinoma, in addition to what you mentioned, hepatitis, of course. Is that okay? Therefore,
Yes,
that
sir.
high risk behavior would have been an important point. Third, I would have appreciated if you had mentioned the stigmas of the liver disease. When the patient has got hepatobiliary disorder and a liver disorder primarily, the stigmas of the liver disease could come through in your journal examination as something useful. So if I were you, I would have started by saying journal examination means performance status, hydration status, nutritional status, followed by no stigmas of liver disease.
Liver disease.
And then examiner will ask you, what are those?
Yes, sir.
What are those?
Sir, Palmer erythema, spider nevi,
1 minute.
gynecomastia.
No, 1 minute, Bachu. Don't start with palm, start with the head.
Okay,
And
sir.
go downwards. So the texture of hair, right? Spider navy, parotid
Spider
hair.
nevi.
Then you
Yes,
come
sir.
down to gynecomastia.
Gynecomastia.
Then you come down to the extremities. Palmar erythema, clubbing.
Testicular atrophy, sir.
No, Abhi, we are still in the arms. Palmar erythema,
Dupuytren's contracture.
Dupuytren's contracture.
clubbing. Don't miss it. And in failure, flapping tremors, not otherwise. And then you're down to ascites, caput medusae, testicular atrophy, pedal edema. This is the order in which you tell.
Okay, sir.
That would have fetched you a better, get you more marks. Okay. What's
Yes,
your
sir.
impression based on this?
So, 53-year gentleman with hepatomegaly, a solitary nodule arising out of the liver, and a recent history of loss of appetite and weight, suffering from a liver mass of malignant etiology, most probably hepatocellular carcinoma.
All right. Now, I am not very fussy about it, but it will be a good idea to mention alcoholic and smoker because they are serious risk factors. No, we know
Yes,
that.
sir.
And rest is, you don't have to repeat recent history of loss of, you've already done that in summary. So 53 years, known alcoholic and smoker with hepatomegaly and a solitary nodule of the liver, probably suffering from a liver mass due to a malignant etiology, likely to be hepatocellular carcinoma. That will keep you proper within your range. You can always argue and discuss about it. Now, why do you say it is first of all a malignant liver?
So first of all, sir, in our history, we can see that the symptoms are limited to the right upper abdomen. That is where the fullness is there. Also, there is loss of appetite and loss of weight, both of which point towards and significant weight loss, both of which point towards a malignant etiology. So further in our examination, we see that there is hepatomegaly and there is also a solitary nodule in the liver. So, sir, we can we can say that the etiology is coming out of the liver, and along with the significant a significant personal history of being a chronic alcoholic and an everyday smoker, which are contributing risk factor to a malignant etiology. So that's why I have come to the provisional diagnosis that this mass is of a malignant etiology.
So you confine to the symptoms which are suggestive of malignancy. You see, all non-specific symptoms is vomiting, weight loss, and anorexia. These are all vague and non-specific symptoms of malignancy.
Malignancies.
Right. So you think it's a malignant disorder on these accounts? I would have been, I mean, you've got so many points to say in the history, no? You could have said a known alcoholic and a chronic smoker of last 30 years with hepatomegaly, and you don't have to confine. These are the points in history you're talking, with significant weight loss and appetite. Okay, and on examination, points on examination, there is hepatomegaly, which again, liver span would have been very important. And with a nodule, with a nodular liver, can you call it? If there is one nodule also, it becomes a nodular liver. But it's a solitary nodule. Right? So, but therefore, you can, others you may not be able to palpate also. No? It's not possible to palpate the whole liver.
Yes, sir.
By just palpating those 5 centimeters. You can't say there's no other nodule. But one nodule is indicating a nodule. Likely to be of malignant etiology. Therefore, you think hepatocellular carcinoma is your first diagnosis. Any differential?
It can also be benign mass arising out of the liver, sir, which might
if you put malignant etiology before you go to the benign, because you have significant weight loss.
Malignancy is more or less accepted, no? We are not calling it benign. When you are saying
any other malignant mass apart from hepatocellular carcinoma,
so it can be so the mass can be coming out of the stomach, sir.
Metastatic. Why you specify stomach? It can be metastatic.
So metastatic, sorry, metastatic.
Basically, it's a malignancy only.
Yes, sir.
But it could be a differential between a primary or a metastatic.
A secondary, yes.
Yeah.
Not secondary, primary or a metastatic.
Metastatic.
Now, why is it not a metastatic liver?
So it is not a metastatic liver, sir, because first of all, through our history and examination, we have ruled out the involvement of other systems, such as one of the most common metastasis to the liver is from colon carcinoma, sir. And in this case,
don't get into colon per se, GIT.
GIT,
no symptoms.
So there's no history or any examination findings positive for any involvement of a GIT carcinoma. So, sir, and sir, also, although we have not been able to palpate the entire liver, but most metastatic liver, more than one nodule might be present, sir.
No, what will be the consistency of that nodule? That's why I'd asked you.
Hard nodules, sir.
Because you don't have firm nodules which are metastatic. Metastatic
hard nodules,
is hard. Okay. So you need to be very careful in examination on that account. Because here, malignancy is a given here.
Yes,
but
sir.
once you take it as malignancy, then these are the questions that will come, primary or metastatic. Okay. Now, suppose I say it's a benign disorder. And the weight loss is known in patients with deranged liver functions all this while, or alcoholic for so long. And he hasn't lost terribly too much. Actually, it's not like he has lost everything in the last 3 months.
So,
which benign possibility? Is there any benign possibility?
So, among males, the most common benign possibility would that be of a hemangioma, because the other benign possibilities such as an adenoma or follicular nodular FNH basically they are more common among females. There is also history of long-term use of steroids or OCPs in case of an adenoma, which is not there in this.
This patient won't be using OCP, so we
yes,
are not.
Sir. So, but not long-term steroids also is not there, sir.
Why can't it be just a cirrhotic liver with the macronodular or micro arrest micro this macro?
Sir, a cirrhotic liver, sir, the stigmata of liver disease might be present, sir. They should be present, sir.
Your examination becomes relevant, no? Secondly, you can't rule it out in the setting of a hepatocellular carcinoma also. Cirrhotic liver cirrhosis can still be
Can be
coexist.
there. Yes, sir.
You cannot swear by it. You cannot say, I just say that it's not there. Are there some other features of cirrhosis which would have been relevant to you? Even if it was cirrhosis of long duration, it was changing towards something nasty since the loss of weight and appetite is sudden.
Yeah.
And it's in last 4 or 5 months. So you should be able to understand that.
Yes, sir.
Okay. Today it looks like a malignant possibility because of these reasons. Okay.
Yes, sir.
And this case would be all about examination because you are waiting to discuss a lot of hepatocellular carcinoma. You must have read it all. But this case would be about your physical findings and history, which we discussed very clearly. Now, suppose this is your working diagnosis with a differential of metastatic, which is not likely, but it's since malignancy is still there, and you do get silent primaries, especially from stomach, from colon. So it is possible to have non-specific primary, but a metastatic liver. So you would exclude that in your investigation. You can't clinically find any reason. So when you're saying not likely, you're saying it based on your history, where there are no features to suggest any primary pathology elsewhere. And on examination, the rest of the abdomen and other systems, they all look apparently normal. So clinically, you can't make out. And that is where your examination of the Virchow's node was very useful. So rather than saying examination of the neck nodes, it should be that node which you should look for. Examination of abdomen for free fluid was very important. Examination of rectum on DRE was very important.
Yes.
That is why, sir, I was trying to tell you, these examination features are not just trivial here. Because that is like, you have to clinically exhaust all your examination skills to exclude a primary.
Yes, sir.
Which is difficult to exclude, but you will still be doing. Okay. Now, this is our working diagnosis. We generally agree with you. How do you proceed?
So we will now proceed. We would like to confirm our diagnosis. We would like to do investigations to confirm our diagnosis, to stage the disease, and to see whether if the patient can be taken for surgery, to prepare for the preoperative investigations of the patient, sir. So to investigate the patient, to confirm the diagnosis, sir, the first investigation we would like to do would be an ultrasound, which would be an extension of the clinical examination, sir. This would be followed by a contrast and CT scan, and preferably a triple contrast, sir. And so MRI can also be used.
Not triple contrast, triple phase.
Triple phase, sorry, sir, triple phase CT, sir. So that we would use that to confirm our diagnosis, sir. Also, as an adjunct, we can have a measurement of serum AFP. After that, sir, to stage the disease, sir, we would like to do this in 2 parts. One, it would be to see the extent of the disease, and the second would be to see the condition of the liver. So to see the extent of the disease, the CCT whole abdomen we have already done, and we would also like to do a CT of the thorax. Further, sir, to see the condition of the liver, we would like to do blood investigations such as a complete blood count, liver function test. We would like to see PT-INR, so total protein, serum albumin. Then, sir, finally, then, sir, if the patient can be taken up for surgery, so then we would like to do the routine preoperative investigations to prepare.
Let's keep it basic.
Yes, sir.
What all information you would get on ultrasound?
So on ultrasound, sir, the nodule that we are, so first of all, we would see the hepatomegaly, sir. The hepatomegaly is the size of the liver and the answer. Secondly, the texture. And so we would also be able to confirm whether there is a single nodule or more than one nodules that we have not been able to confirm by clinical examination. Further, whether the texture of the nodule is similar to that of the remaining liver or it is different.
More?
And so we can also add a Doppler and see if there is a...
You're not going beyond liver. You're just so focused on your diagnosis.
So rest of the abdomen,
The abdomen, you will look for any primary somewhere.
Yes.
You will look for any
Gallbladder, pancreas.
It's everything.
Stomach.
Try and see.
Although
Don't
GI is difficult, but still you can have some idea.
some
Yes.
idea. Ultrasound of the abdomen, whole abdomen, including liver.
His
What
notes.
fibroscan?
Yes, a fibroscan, sir, basically it tells about the extent of fibrosis, sir.
When do you consider? He is alcoholic for 30
Sir,
years.
in case of, sir, if we see any signs of cirrhosis, sir.
So what would
Patient
you
with 30 years cirrhosis, there is likely that he might have some chronic liver disease. That has got bearing on treatment also, because your treatment planning will depend on his underlying liver status.
Underlying liver conditions, yes.
Okay, because actually you need just not the performance status of the patient, you need the performance status of the liver also.
Liver, yes, sir.
For that, you have to do many investigations. Ultrasound, anything else? So it will exclude your other possibilities, and it will include your diagnosis, whether it's correct or wrong, and it will tell you about the IHBRs and EHBRs. It will show you about the metastatic
Portal systems.
It will show you the whole abdomen. It's an extension of clinical examination, absolutely. And
splenomegaly,
exclude any
evidence of portal hypertension.
Yes. All those causes will come in here. Then you are going for the triple phase CT. Which phase is most relevant in this case?
So in this case, sir, the delayed phase would be most relevant, sir.
So all are relevant, but delayed is more relevant. Now, why delayed?
So because hepatocellular carcinoma, it was markedly differentiated by an early washout in the delayed phase, sir.
So basically for the washout, and also anything else that the triple phase will show you, which is important, has a bearing on the management.
So it will show us if there is any involvement in the portal system, sir.
Correct. So you've done the initial investigations, and you have done a CT triple phase. You said I'm doing investigations also to stage the disease. How do you stage it?
Sir, staging of the disease, sir, is based on if we go by the TNM staging, so there's the TNM staging is there, sir, and then sir, there's also the Barcelona staging, sir. Sir, in case of the TNM staging, sir, T1 is single nodule less than equal to 2 centimeters, or nodule more than 2 centimeters without vascular involvement. That is T1A and T1B. T2 is a single nodule more than 2 centimeters, single nodule more than 2 centimeters with vascular involvement, or multi-nodules, but all less than 5 centimeters. T3 is multi-nodules, any one of them more than 5 centimeters. And T4 is if there is a direct extension, if there are multiple nodules more than 5 centimeters with direct extension into the portal vein or the hepatic vein, or there is a direct extension into an adjacent organ such as the gallbladder.
Okay, rest can read, others can read it. The idea was to just run you through that. Now, how does stage influence your management?
Sir, the current guidelines for management, sir, is based on, sir, the Barcelona staging, sir, and sir, depending, the Barcelona staging, sir, basically, if the performance status is 0, and if the child, it takes into account the performance status, the child.
That's why Barcelona staging is better and superior to the bland TNM, because TNM is one method of passing it over to the other unit or some other system. This is the stage. This is just the, as they say, the anatomical classification or staging. But Barcelona includes
performance status
and the CPT.
And this is a child Pewter score, sir.
So what is the CPT? Take us through that quickly.
The CPT has 5 parameters, sir. The first is the bilirubin level, serum bilirubin, serum albumin, presence of ascites, PTINR, and presence of hepatic encephalopathy, sir. Depending on that, it is divided into child Pew A, B, and C. So usually child Pew A, in case of hepatocellular carcinoma, child Pew A is along with the performance status is taken as a very early disease, or and B, which can be taken up for resection. B would be I mean, I was not able to find at most places a lot of controversial things were given, like it is considered borderline and it may be taken up for resection or it may be taken for non-curative treatment. And C would usually indicate advanced disease, which would not be taken up for either transplantation or resection. So
you're right. And you know, is there any role of MRI in these patients? Especially with the, you know, a different, not with not the standard MRI. I'm only asking you.
So I'm not sure, sir.
This was in one MDT that this point was raised using gadoxetate disodium. They are able to pick up the precursors. The other nodules are also there, no? You just cannot be able to pick them up. So that also helps in planning. Some people like to do that. But by and large, most of us rely on the triple phase CT for its planning. Now, when you look at the borderline case, what is the controversy? Why is there controversy?
So whether it is we have to decide whether it is resectable or not, sir.
What would make it non-resectable?
So multiple nodules, sir. Nodules more than 3 centimeters in size, or a poor performance status of more than 0, performance status 1, 2, or if there is staging, if it is a N1, that is a regional nodal involvement or a
the regional node.
metastasis.
This is the regional node.
Sir, regional nodes would be the hilar, sir, the hepatoduodenal nodes, the caval nodes, and sir, nodes along the hepatic artery.
What investigation would pick these nodes up?
Sir, CCT whole abdomen would be able to show the involvement of nodes.
So initially ultrasound followed by CCT, you'll be able to pick it up. So that is important. And in those cases, what do you do? Suppose it is borderline or non-resectable. There's a difference, no? Borderline, you'll still try to make them resectable somehow. How do you approach that?
So we can go for chemoembolization, sir.
What do you use for that?
Sir, not able to recall.
Is it the artery or the portal vein?
Sir, artery, sir, hepatic artery. Because the tumor is mostly supplied by the hepatic artery, sir.
All tumors, you know that. They traverse in the portal blood, but they are supplied by arterial blood because they need oxygen.
Yes.
Okay. So embolization for whatever, even metastasis, the embolization would be in the hepatic artery only. And yes, you can do that, I mean, as a part of, as a preparatory approach to these cases also. Okay. Yes. And this usually is beyond your scope by and large. So what surgery, when you talk about surgery, what do you mean by resectable? What do you do?
We basically, sir, we look at the functional liver remnants, sir, and depending on that, we decide whether and the involvement of the tumor, how much of the liver is being involved. We can go for a left hepatic, depending on which side is being involved, a left or a right hepatectomy.
The broad heading is resection.
Resection, sir.
Resection and transplantation.
Yes, sir. Yes, sir. Resection and transplantation, sir.
Right. That's a straightforward approach that is followed in these cases, no? Can you do partial resection? You can't do that, no? Can you? Because it's in the background of an unhealthy liver.
Unhealthy liver.
Not a healthy liver. So therefore, you need to know the rest of the liver, its performance. You can do less also, but by and large, it's not a healthy liver. And usually, what is the survival in these cases?
So,
early stage with resection.
With the early stage with resection, yes. Sorry.
So I'm not sure.
So it's not a death sentence anymore that people used to believe. In early stage, with where you can get a clear resection, it's possible, but depends on many factors. No? Performance status. Very
performance status, involvement of the portal system, or if associated disease is present.
Do you think your patient is a resectable case going by your presentation? You'll be investigating, of course, I agree.
Otherwise, how do you feel? Otherwise, how do you feel? Clinically, patient is...
So since the patient has not, I mean, in any history and examination, there are no
No
symptoms
ascites,
suggestive
he
of,
has no ascites,
yes, of no
there is
suggestive
no stigma
metastatic
connected liver
disease, and
disease,
there is no
Pretty well,
chronic
no
liver involvement also.
encephalopathy.
pretty well preserved. And
Well preserved.
if treated early, it can give you a very good outcome, right? It can be one of the better cases for that. Now, suppose it's in the background of cirrhosis. What is it that becomes a challenge in surgery? What is the challenge?
So in case of, sir, the liver becomes very friable, sir. So
No, not
there will
fiber
be a
only.
lot of bleeding, sir.
Before friability, technical part, how much liver residue you expect to
Yes, sir.
have?
Functional liver remnants.
How much for a normal liver and vis-a-vis a cirrhotic liver? Same?
No, sir. So for a normal liver, 40%,
Around 30% is
30 to 40%.
acceptable. But in cirrhotic liver, it should be more.
If you would require a larger chunk of liver to be there, which is functioning, because naturally, if you have 10 people who are anemic and 2 people who are wrestlers, they will do the same work.
Yes.
So the remaining part also is important. So that decides the outcome. Therefore, you need to really very carefully discuss these cases in the MDT. The entire preoperative management is about optimizing the patient, discussing the performance status of the patient, of the liver, his remnant, the remaining liver, etc. Otherwise, the outcome can be dismal. This disease is not forgiving, so, because usually it is very late when it presents. By and large, it is late in its presentation. What do you do to a non-resectable case?
So we can go for we can go for transplantation. We can go for
Non-resectable is not for transplantation.
So we can go
Non-resectable
for
means advanced disease.
so then
Advanced disease patient is not for
say
transplantation.
if for among non-curative treatments, so we have chemoembolization and we have sorafenib. Sorafenib can be
Before
used.
that, any local treatment, any ablative surgery?
Yes, radio frequency ablation is there, and percutaneous ethanol injection can be done. So it's usually done for very early or early stage disease, but with us when there is associated liver dysfunction, sir.
That is when you cannot be doing the surgery. You have no
Dissection,
choice,
sir.
no? And so, and any other option?
So
You mentioned about chemoembolization, right?
yes, sir.
You must have read it theoretically, but if you were asked, how does one reach there? How do you reach the hepatic artery? It's a branch of which artery?
Hepatic artery is a branch of the proper hepatic artery, sir, which is a branch of the celiac trunk, sir.
Good. And this is asked. Proper hepatic artery divides into one. That is hepatic. What is the other artery?
So proper hepatic artery gives off the gastroduodenal artery and the superior pancreaticoduodenal and the hepatic arteries. Proper.
So that you should know. This automatically comes along with it. Any role of portal vein embolization? Suppose the remnant liver is very limited, or you want it to expand. Patient is otherwise
Yes,
fine. Can you do something? These are the maneuvers when you can actually occlude it, let the liver kind of hypertrophy, as you can use the term,
yes,
and then you can achieve those 30 to 35% function is mandatory for survival. No? So that is where you can do it. In addition to this, suppose this was a metastatic disease. On ultrasound, you find out that there's a couple of more nodules. Is there any role for doing more than what you've just told us? Or I'll be direct. Is there any role for establishing a diagnosis, doing an image-guided core or a FNA?
It is only required in cases where the diagnosis is uncertain, sir. But usually with CT, we would be able to. So with CT, if it is a metastatic disease, also we would probably be able to find the primary, sir.
You may not be able to find it, but it is a distinct appearance on CT. The hepatocellular carcinoma is almost, the diagnosis can be clicked on.
Yes, sir.
triple phase. It's a very, in the last phase that you pick it up.
And then, sir,
what-
the point for doing FNA or biopsy will be in situations where you're not going for upfront surgery.
Yeah, when
If
you
you're
need
going
to
for some
put it
adjuvant
on,
treatment,
yes, whether it is gallbladder or pancreas or liver, usually nowadays they recommend it when you're putting the patient on some kind of a neoadjuvant
Palliative.
protocol. Neoadjuvant protocol, that's one.
Yeah.
Or two, palliation in terms in a disease where you're doing nothing else. How can you put the patient on any therapy unless you have some
Confirmed
diagnosis? Yeah, these are the indications. And don't forget to mention that before patient is taken up, we need to optimize, and that requires a multidisciplinary team management where you involve the hepatologist, where there are people who look at the fibroscan very, very carefully, and then you use the Barcelona. Where is Barcelona, dear?
So Barcelona is in Argentina, sir.
Don't tell me you're in Calcutta. Barcelona, they watch.
Oh,
football.
Spain. Sorry, sir. Spain. I'm so sorry, Spain. So sorry, sir.
It's a Spanish.
Yes,
city.
sir. Spain. Yes.
So that's where this was evolved. It was just a consensus meeting. They didn't do anything about it. People got together and they, like you have Atlanta. Atlanta, where is Atlanta?
Atlanta is in US, sir.
Very good. Whenever in doubt, say US. So you're right. So that is where Atlanta for the pancreas, they got together. So this was a much better way to approach it. And you need to optimize your patient. Keep the thing open to the patient and also to the attendants. And what kind of a, if suppose the liver, both sides are involved and you're not going to get that kind of a margin clearance, or you're not going to get that much of liver, then you have to look at the transplant, which we would not go in there. What are the chances of this transplant developing hepatocellular carcinoma?
So I'm not sure.
Also read something there. Can't tell you all the time.
Yes, sir.
There is a
same factors are remaining. If the
Yes.
same factors are remaining, then even the transplant patient may have.
Because it's nothing wrong with the liver, it's the patient's problem. No,
Yes,
liver
sir.
is one poor organ that is trying to clear off, detoxify, work hard. You got another segment, and it's not the complete liver that comes. It again has to start functioning, develop. So those risk factors have to be taken care of. Patient needs monitoring. Which markers are used for monitoring subsequent to surgery? That's the last part. 3 minutes remaining.
The serum alpha-fetoprotein is used, sir. Once it has come back to the normal level, preoperatively or once at the time of diagnosis, we take it. If it is elevated, once it has come back, we can use it later on to see recurrence.
Any role of CEA?
So CEA would be, sir, in case of metastatic disease, sir, CEA would be the marker of choice.
Why you should know? I asked you for the same reason. So AFP for the primary, CEA for the secondary, both are non-specific, but they're useful as prognostic markers because if you have a baseline, then you can use it. In which situation patient is not improving, but CEA keeps dropping? That's a bonus question for all of you. Metastasis you observe in colorectal cancer, otherwise metastasis to the liver.
Yes.
CEA was steady, then it starts dropping, but the patient is worsening. Metastatic disease becomes, liver gets started with metastasis. There's no production of the CEA. No, so it's to be very carefully seen. So not in isolation any marker would do. So you
differentiation and changes.
So
Differentiation and changes.
Yeah, and imaging is very important alongside. Okay,
Yes,
I think that should be all. If you have any question, you can ask Dr.
You have, so you said sorafenib. Do you know any other newer drugs being advised for SCC? I mean, more advanced disease.
So sorafenib, so
Yeah.
bevacizumab, sir.
There are newer checkpoint inhibitors being used, and they claim that these drugs are as good as sorafenib, or some are more effective, like nivolumab.
Okay, sir.
But you did well. Don't worry about it.
Yeah. You have faced the most toughest examiner.
Very well done.
So actually, the presentation methods, the way you present, that is the first basic thing you should build up. You should give a good history. You see, these are all hypothetical cases. The more important is your real-time examination, where you have a patient in front of you, and you cannot just say something which is not there. In virtual case, you just add up many things to come to a closer diagnosis. But in patient now, exam is going all physical. There is no question of virtual exam now.
Good for everyone.
Yeah.
That's good for everyone. They'll also learn to present.
Yes, sir.
And we are doing all scrubs also would be physical only now. And that is how we are going to do it. So that they, it's better, like Dr. Shah was mentioning, nothing like really facing it and presenting it as it happens in the exam. But I thoroughly enjoyed your presentation. I hope you enjoyed it as much. That's what is more important, right? Thank you very much. Thank you, Dr. Shah.
Thank you, sir. Thank you very much, sir. Thank you.
Thank you, sir.
Thank you. Any question from any of the participants?
No, so we don't have any questions.
No question.
All right. Thank you. Thank you very much.
Yeah, you presented very well. Milind, very
you,
good. Very
Thank
good.
you.
Thank you. Tomorrow you have a class?
Yes, sir. Tomorrow morning, sir.
Journal club?
Journal club, yes, sir.
Who is taking? Dr. Shomen Das?
Dr. Arko Prova, sir.
Okay. You have posted the topics?
Sir, I will just post it, sir. I have
Okay.
both the, I'll just
Okay,
post it.
Thank you.